Good morning, everyone.
Good morning, everybody.
Morning.
Good morning.
Good.
Beautiful weather out there.
Good morning.
All right. Can't get it.
Well, good morning, everyone. Happy St. Patrick's Day, everyone. Well, just about anyhow. We hope you're all enjoying the early spring and welcome to Trio Maryland's March Zoom meeting. It's great to see everyone. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests today, and thank you for attending. Today's topic is disparities in chronic kidney disease. It's a very important topic for the National Kidney Month. Next month, just for your information, is April Donate Life Month. And it's a wonderful time to volunteer at your OPO, your transplant centers, and in your community in general. There will not be a Zoom meeting next month, so maybe that'll give you time to extend a welcome helping hand.
Good morning. Today's guest speaker is Dr. Rochelle Cunningham, a nephrology specialist from Mid-Atlantic Nephrology. Mid-Atlantic Nephrology is a physician-owned and physician-governed group of nephrology providers organized to enhance the health and well-being of patients by providing high-quality and compassionate nephrology care. Say that nephrology thing 10 times, it's a killer. Dr. Cunningham studied medicine at the University of Texas Southwestern in Dallas, Texas. She completed her internship and residency in internal medicine at the University of Maryland Medical Center, and then her fellowship in nephrology also at the University of Maryland Medical Center. Dr. Rochelle is board certified in internal medicine and nephrology and has been in private practice at Mid-Atlantic Nephrology Associates in Baltimore since 2018. We would really like to thank Patty Dash, the Executive Director of the National Kidney Foundation of Maryland and Delaware, for inviting Dr. Cunningham to speak to us today on this important topic. We're fortunate to have you, Dr. Rochelle, here today to speak to the Trio Maryland community. Thank you for presenting to our group, and I now turn the program over to you and Patty Dash.
Thank you. Thank you so much, Michelle and Marty. You are certainly dear friends to the National Kidney Foundation, and I'm honored to call you friends of myself personally. I'm going to just give a few little updates for you before we turn it over to Dr. Cunningham. We know that this will be an inspiring and interesting presentation, and we hope you learn a lot. So it's National Kidney Month, and I am always excited in my orange today. And I want to share just a little bit about our focus this year. At the NKF, we're committed to kidney equity for all by helping to create a healthcare system that values diversity, promotes inclusion, and ensures that everyone has an equal chance at a healthy life, regardless of their ethnicity or their cultural background. This month, during National Kidney Month, we are shining a spotlight on the importance of health equity by celebrating our progress and acknowledging the ongoing efforts ahead. So we invite you on this journey towards a healthier and more equitable future for all, making this year's National Kidney Month more impactful than ever. We have a toolkit. If you go and search for National Kidney Month toolkit, has a bunch of graphics you can use, some posters you can use, focus on our risk quiz that you can take, which I'll drop into the chat. But again, kidney equity is health equity for all. And with that said, thank you all for having us, and I'll turn it over to Dr. Cunningham.
Thank you, Patty. And thank you for the National Kidney Foundation for inviting me to speak on this very important topic. As you've heard, I am a nephrologist. I've actually been doing this for many years. I actually started my career at the University of Maryland. They didn't mention that. So I was actually at Maryland for many years, was part of the kidney transplant program at that time and saw a lot. And then after that, I joined Mid-Atlantic Nephrology. I'm now in private care, primary nephrology. And so I don't really see transplant patients as much as I did when I was at the University of Maryland, but I do take care of transplant patients as part of my outpatient practice. But mostly I see patients with chronic kidney disease. And I'm kind of glad I was chosen to give this talk, because what I find out in the community, there's just not a lot of health literacy on chronic kidney disease, meaning what does it mean to have chronic kidney disease? So the first part of my talk is going to be, I call it a primer on chronic kidney disease, meaning what does it mean when someone tells you that you have chronic kidney disease? Because when I get patients who are referred to me from their primary care provider, they really have no idea why they're there, first of all. And second of all, they'll ask me, what does it mean to have kidney disease? So I'm going to go over kind of a short half, I guess a third of the presentation will be about what does it mean to have kidney disease and some of the disparities and the reason why they exist in patients with chronic kidney disease. And then we'll look at disparities in kidney transplantation. And then, as Patty talked about, the National Kidney Foundation's role in addressing some of these disparities and health and kidney equity. And as I've told Patty, I'm okay if you guys have questions during the talk, just put it in the chat box or raise a hand and let us know, and we can stop and talk about it, because there's going to be a lot of information. And I really like for my patient to have understanding. That way they can take better care of their health. And that, I hope, will translate into better kidney outcomes. Okay, first, when, I'll get a minute here because the bar is in the way. Second. There it is. Okay, so this is a primer on the role of kidneys and what does it mean to have chronic kidney disease. So when someone says, I have chronic kidney disease, what does that mean? It means, when I tell my patient, it means you have reduced kidney function. So what do the kidneys do? The kidneys filter urine, filter blood to make urine. So they filter out the waste that accumulates. And so in the bloodstream, the waste should be very, very low. But in the urine, there's a lot of excess waste. And also the kidney's role is to make urine, right? So all the excess water that you take in that you don't need, the kidney's job is to get rid of it. So the kidneys filter the blood, clean out all the toxins, produce urine, and gets rid of the excess urine, right? And having chronic kidney disease means any condition that damages the ability of the kidneys to keep you healthy, meaning any problem in these steps that I just talked about means you have kidney disease. So as the kidney function declines, the waste products build up in the blood, and that can make you sick. So what people tell me, so when I see patients in the office, I'm actually looking at the kidney test, and we're going to talk about that shortly. And then we can see if the waste products are starting to build up in the bloodstream. And that's what that kidney test is. When people tell you, I'm going to send you to the lab to check your kidney function, is a specific blood test we're looking at to see if these waste products are building up in the bloodstream. And it's true, if the waste products get really, really high, this makes you sick. And that's what kidney failure is. Now, you also develop a lot of other problems when you have chronic kidney disease and when this progresses over time. What people don't know is the kidneys are responsible for doing a lot of things. First of all, people with chronic kidney disease are more likely to have hypertension. Most will have anemia, and that's when the blood count drops. And that can make you very sick, by the way. In the old days, we didn't have medicines to get your blood count up when you had kidney disease. So most patients in the old days would get blood transfusions, and that caused a lot of problems, especially if we were trying to transplant someone. But yeah, so the kidney is responsible for maintaining your blood count. And people are like, what? Yes, the kidneys do a lot. It also is involved in calcium and phosphate metabolism. And so my patients, I send them to the classes to talk about this. What does it mean when your calcium and your phosphate's kind of out of control when you have chronic kidney disease? So the kidneys are responsible for maintaining that. And also when people develop progressive chronic kidney disease, they have a tendency to become malnourished. Kidney failure can also result in nerve damage. And that's really when we're approaching stage 5 chronic kidney disease, when you start to see symptoms like that. Complications of chronic kidney disease, I mentioned some of them just previously. Heart disease, in that, when the kidney's job is to get rid of this excess fluid, and when it doesn't do that, you can start to have fluid problems. You start to get swelling in the legs. Sometimes the fluid can go to the lungs and lead to congestive heart failure. Kidneys are responsible for maintaining potassium, calcium, phosphate. The acid can build up in the bloodstream as you lose kidney function, and we talked about the anemia. For children, they tend to have problems with growth, and they have growth retardation. They can also have high blood pressure, infections if they have urinary issues. That's the cause of their chronic kidney disease, cognitive problems, and as I talked about, urinary problems, if that is the cause of their reduced kidney function and chronic kidney disease. Now, I do go, when my patients come in for an initial visit, we talk about the staging of chronic kidney disease. So I told you what it is, right? And what the kidneys do. So what are we looking at specifically? When I send a patient for a blood test to measure their kidney function, I am looking at what's called creatinine. And so patients will look at me when I say, I want to see what your creatinine level is. And they're like, what is that? And I'll tell you what it is. So creatinine is basically a waste product, right? So we eat, your body metabolizes the food that you eat, creatinine is produced, and then the job of the kidneys is to flush this creatinine out into the urine. So I tell people, when I'm checking your creatinine, that number should be very, very low in the bloodstream. So what's normal creatinine? 0.7 to 1.2 in most labs, right? And when that creatinine numbers start to go up above that 1.2, which is the upper limit of normal, we know that the kidneys aren't doing their job in terms of flushing this waste product out into the urine, right? Now, this other measure underneath is called cystatin C. It's actually a little bit more accurate than creatinine because other things can affect the creatinine number. But I use this for patients when I'm not sure if their creatinine number is giving me an accurate measure of the kidney function. Now, so that's the blood test that I send my patients for when I'm looking for seeing how well their kidneys are doing. So I'm looking at that creatinine number. But what I also send them for is a urine sample too. So when patients come to me and I tell them, I'm going to check your kidney function, I'm looking at that creatinine number, and I'm looking at the urine for either blood or protein, or what it says here is albumin. Albumin is a type of protein. And what I'm looking at is the albumin to creatinine ratio. And so the kidney's job is actually to filter, right? So when urine is starting to show up in the urine, we know there's some type of kidney damage. So protein in the urine, albumin or protein in the urine is a sign of kidney damage, right? And I tell people the more protein, usually the worse kidney damage, right? And so what is normal protein? And we'll go down to this area here where it says determine albuminuria. So remember the protein category. So normal is less than 30. When you see A1, that means albumin to creatinine ratio of less than 30, that's normal. And most of us have, God willing, an albumin to creatinine ratio of less than 30. And as this number goes up, that means you're spilling more protein in the urine. So, and A1 is normal. A2, you're spilling between 30 to 300 milligrams of protein. And A3, you're spilling greater than 300 milligrams of protein, right? And when we stage the kidneys, we're looking at that creatinine number, but this is what I tell my patients. First, we get the creatinine number, and then some brilliant person a long time ago created a formula to figure out the filtering rate of the kidneys, right? So based off that creatinine number, we put it into a formula, and we get how well the kidneys are filtering, right? And that's the GFR number, and it's an estimated GFR number because it's a calculated number, right? So G1 is normal, meaning the filtering rate is greater than or equal to 90, and that's normal kidney function, right? So I have patients who have normal filtering capacity, meaning their GFR is greater than 90, but they're spilling protein. Remember, protein or albumin is in the urine, which is a sign of kidney damage. So they actually are part of the staging paradigm, meaning they have chronic kidney disease because even though they have normal filtering function, meaning our GFR greater than 90, they have evidence of kidney damage with protein or albumin showing up in the urine. So G1 is when that number is greater than 90, the filtering number. G2 is 60 to 89. I have a lot of patients in that G2 category. G3 is where most of my patients fall. And this is important because that when you have a filtering capacity of less than 60, you fall into the the G3 category, and it's actually divided into a 3A and a 3B. Of course, 3A is better. 3B means you have less function. So 3A, your GFR is between 45 to 59, and 3B, your GFR is from 30 to 44. The reason why this is important, and this is usually when patients are referred to me, when their GFR number falls below 60, because this is when we start to see health problems start to appear at this point. And we'll go over that further. What does that mean? But this is when there's kind of a bifurcation where we have people who are going to have a GFR of 60 or less than 60 that are going to do perfectly fine, meaning they're going to live the rest of their lives without developing kidney failure. And then we're going to have people who are what we call progressive, meaning they're going to go on, their kidney function is going to continue to decline. And these are the people that are going to end up on dialysis or end up with end-stage kidney disease. G4 is an important category because this is where we tend to lose a lot of people in this category, G4 leading into G5. And I'm going to talk about that a little bit further on in the talk about what do we lose our kidney patients to. yeah, when my patients come to me, they normally, they're so afraid that they're going to die from kidney failure. And I'm like, that's actually not what you're going to die from. Most of our patients with chronic kidney disease don't die from kidney failure. I tell them the hardy ones make it to kidney failure. Most of our patients die from heart disease, cardiovascular disease. And we're going to talk about that and the different types a little bit later on. But we don't lose patients to kidney failure. Of course, when you get to kidney failure, risk of death is higher, of course. But most of patients don't make it to stage 3, 4, or 3, 5. And I talked about the proteinuria, and that once you get to these higher categories of proteinuria, that means you have typically more kidney damage. There are a number of reasons to have chronic kidney disease, and I'm going to go over that a little bit later. Of course, hypertension is one of the more common reasons for having kidney disease. You will develop some electrolyte abnormalities. People who are progressive, I talked about that. Structural abnormalities, we'll talk about that later. There are hereditary types of kidney disease. I'm not going to really focus on that. I'm going to focus on the most common causes of kidney disease in this country, which is diabetes and hypertension. But some patients who have kidney disease will have blood show up in the urine or white cells show up in the urine. People with kidney stones actually can have kidney disease. And I tell patients that this is actually not a primary type of kidney disease, meaning the disease doesn't originate in the kidneys, but it's more of a plumbing issue. So urine is very toxic, actually, and I tell my patients urine should flow one way, right? And that's out. And when you have kidney stones, meaning a blockage of urine flow and the urine flows back into the kidneys, it can lead to kidney failure. So, but patients who have recurrent kidney stones and recurrent, we call it obstruction, can actually have developed chronic kidney disease and go into kidney failure. And then nephrotic syndrome is a type of kidney disease, and we're not going to really talk about that much. So here's where I kind of diverge from other kidney specialists or even other, I guess, primary care providers. So we were told, this was many years ago, that our patients aren't referred to us until they have a GFR 30. And if you go back to, that's in this G4 category, that's when patients would be referred to us, right? I feel that by that time, a lot of damage has occurred. And by the time you make it to me, there's not a whole lot I can do about it. So I do encourage, at least the private practitioners, please refer your patients to me sooner. Yes, I'd like to see them in the G1, G2 category, because then we can start to work on these modifiable risk factors for chronic kidney disease. And we're going to talk about that later. But I do prefer to see patients earlier in the course of their disease in reference to chronic kidney disease. By the time they reach stage 4 and 5, these patients are more likely to have progressive chronic kidney disease and more likely to go on to end-stage kidney disease. And, of course, a nephrologist is needed at that time. All right. So patients often ask me, but I feel fine, Dr. Cunningham. What are you talking about? Something's wrong with my kidneys. I'm like, yeah, it's true. People, most of the times you feel perfectly fine. And when you look, if you Google and you look online and you see all these symptoms that they talk about, yeah, these do occur. But the symptoms that you're seeing here are people with really advanced kidney disease. So we don't really start to see symptoms until people have perhaps stage 4 going to stage 5. That's really when people start to experience symptoms of chronic kidney disease. And those patients are actually on their way to kidney failure. But as you see here, fatigue is actually pretty common. Nausea, vomiting, loss of appetite and weight, or anorexia, very common in stage 4, stage 5. Increased urinary frequency. This is a problem because patients will tell me, oh, I'm peeing fine. I don't have any problems with my urine output. And I'm like, well, this is what happens. As your kidney function continues to decline, you will notice that your urine frequency is picking up. That is not a good thing. That's kind of like the last gasp. Right. And you're peeing pretty frequently because the kidneys are losing their ability to dilute. I mean, and then you just have a lot of urine output. And after that point, you stop peeing. So that's actually when I hear my patients who are advanced kidney disease, stage 4, stage 5, and they're like, boy, I'm just going really, really a lot. My kidneys must be doing really well. That's really not a good sign, actually. And that's when we begin that talk about dialysis. And because when you stop peeing and then fluid just builds up, and you get into a lot of trouble. And that's when you require emergent dialysis. Now, I do have a couple of patients that I've had to start on dialysis, even though they were in the stage 4 or 5 category, but all of a sudden they developed diffuse itching. That actually is a sign of kidney failure, and people are not aware of that. I had one patient who was doing fine, and all of a sudden around the Christmas holidays, he developed diffuse itching. And I'm like, oh no. And he's like, it's just so intense that he felt like he was going to scratch his skin off. That is a sign of kidney failure, and it's one of the indications to start dialysis. Altered mental status, that occurs with pretty advanced kidney failure, and neuropathy, that you can see that with patients on dialysis and advanced kidney disease. Edema swelling, as I mentioned before, occurs with a pretty advanced kidney disease, as well as shortness of breath, heart problems, and of course decreased nor urine output. But most times, though, as I mentioned before, when you have chronic kidney disease, especially if you're early, most people don't have any symptoms. And I've had patients who I've taken care of, they come in with a creatinine of 10 and feel completely fine. And when do we start dialysis? Usually when their creatinine is around 5 or their GFR is around 15 or lower. That's usually when patients require renal replacement therapy, some form of dialysis. And of course, we refer people over for kidney transplant when their GFR falls around 20. But I have to say, most time people have no symptoms.
Dr.
So we're
Cunningham, we have a couple
yes,
questions, if I
sure.
could
Mhm.
interject for you, okay?
No
This
problem, no problem.
question is a context for a question from Stefan, I think it is, or Stephanie, is it Stefan? So context for question, a transplant eligible person is having an increase in calcification in the vessels where a transplanted kidney would need to be connected. A study seems to indicate that dialysis may increase calcification.
Oh, absolutely. Yeah, because, well, just having chronic kidney disease, you get an imbalance of calcium and phosphate, right? So we call that uremia or the uremic milieu, and you can get diffuse calcification. Although patients who have diabetes can also get diffuse calcification, right? So that's one of the risk factors we're going to talk about later on. But yeah, that is an issue and something that the surgeon, of course, will have to address in terms of
Okay.
receiving the donor. Yeah.
And there's a follow-up
Okay.
question. Is there a source, NKF info or other, where a patient can get guidance on minimizing or mitigating the buildup of calcification, or source for how transplant surgeons work with that matter?
Wow, you would have to probably, that's a conversation that you would have with I'm assuming this patient's is a kidney transplant patient or is being evaluated for a kidney transplant. Is that, so if they are being evaluated for a kidney transplant, don't forget, most of our patients who need a transplant are in these high risk categories, meaning they're diabetics that tend to have calcification in their vessels, right? So if you're saying, would that make it difficult? Yes. Yes, it would be challenging, but not impossible, right? Because most of our patients have these kind of issues, right? Most of our patients are heart patients. Most of our patients are diabetic patients, so they have calcification, maybe increased calcification. But that is something that they have to talk with the surgeon when they go in for their evaluation for a kidney transplant. Ask that question, and they can talk to the surgeon. Like I used to work with Dr. Bartlett back in the day at University of Maryland, and so it turns out he is a vascular surgeon, right? So he's completely aware of the calcification, and sometimes our patients don't have the healthiest vasculature, right? That doesn't
So
mean you can't. I'm sorry,
I'll
go ahead.
take a look also, Dr. Cunningham, and
Okay,
post any resources that I may find for them as well. And then
yeah,
there's one other question from
sure.
Mike.
Okay.
Are there any systemic diseases that can prevent false positive tests associated with kidney disease?
That can prevent false, meaning you get a positive test. So are there some diseases that will give you a positive test and it's a false
Yeah,
positive
any
test?
systemic diseases that can present a false positive result associated because of kidney diseases, what I'm reading.
So what I think they're trying to say is, so like when we do that, so what we're looking for when we're talking about chronic kidney disease, that creatinine number. So are there some things that can affect that creatinine number? I'm thinking that's what they're saying in terms of the diseases that affect that number. Oh, absolutely. Yes. I mean, systemic diseases, for example, people who have congestive heart failure and are on medications for it. Yes, right. So I have patients right now who will have an elevated creatinine, but it doesn't mean that their kidney function is worse. And this person has been on high dose diuretic, right? So it'll give an elevated creatinine. It doesn't mean they actually have worsening of their chronic kidney disease. So this is what we call acute renal failure or acute kidney injury, where we see the elevated creatinine, which would say, oh, my kidneys are much worse. But once we fix the underlying disease or whatever that systemic disease that I'm not sure what he's referring to, but if we fix that, we'll see improvement in the creatinine number, right? So my congestive heart failure patients will sometimes go into kidney failure, but it doesn't mean that their kidney function is worse. It means that what we were doing to them, either their heart function was worse at the time or they're on medications, and so it raises their creatinine. But as soon as we fix those things, the kidney function usually improves. So I hope I answered their question.
Mike noted lupus.
So yeah, so for okay, so for lupus, lupus is actually I have a number of lupus patients, right? And we do follow their creatinines. It's really a good function, a good marker of their kidney function. So no, I don't think so. Was the answer then for that? Anything else? Now we're going to do the what I call startling statistics, and because I think we need to know the numbers, because not that I don't feel people treat kidney disease as a well, maybe I do. I don't think people see it as being as serious of a disease as it is. So let's go over the numbers, and I call them startling statistics. So in this country, kidney disease is the 10th leading cause of death nationwide. It affects approximately 1 in 7 adults, which means 37 million Americans are affected by chronic kidney disease. 1 out of 3 adults in the U.S. are at risk for kidney disease, and what's really startling is approximately 90% of Americans with chronic kidney disease do not know that they have it. Startling statistics continued. More stats. CKD is more common in women, 14% versus men at 12%. 16% of non-Hispanic Blacks have chronic kidney disease. 13% of non-Hispanic whites have chronic kidney disease. 14% of Hispanics have chronic kidney disease. And what's very clear to us is that CKD is more common among as you age, meaning people greater than 65, 38% of them have chronic kidney disease. Between 45 to 64, it goes down to 12%. And then between 18 and 44 years of age, it goes down to 6%. So more common in the elderly versus the young, although young people can get chronic kidney disease as well. And this is, if you want to see this data that talks about the statistics, this is from the USRDS data of 2020, and just go to the NIDDK site and type in USRDS data 2020, and it'll pull it up if you want to see these and you want to review it yourself. Okay, more of the startling statistics. This is about end-stage kidney disease. These are people who have had kidney failure. So nearly 808,000 people in the U.S. are living with end-stage kidney disease or end-stage renal disease, the old terminology, with most of these patients, 69% on dialysis, and 31% of these patients have a kidney transplant. We would love to see that number much higher because we know people do better with a kidney transplant, but these are the current stats. Men are 1.6 times more likely to develop end-stage kidney disease versus women. Blacks are nearly 4 times more likely to develop end-stage kidney disease versus white Americans. Hispanics and Native Americans are about 2 times more likely to develop end-stage kidney disease. Asians are about 1.5 times more likely to develop end-stage kidney disease. And although we know that Blacks make up only 13% of the population in the U.S., they account for 30% of the people with end-stage kidney disease. I do talk about this when I see patients in my office. I tell them, there's something going on in terms of why, if you go to our dialysis unit, 1/3 of those patients are going to be Black. So these are the things that we need to address, and I'm going to talk about that a little bit later on as well. More on startling statistics. Blacks tend to have end-stage kidney disease related to what? Hypertension versus any other ethnic group. Since 2000, and we don't understand this stat really, the number of Hispanics, Native Hawaiian, and other Pacific Islanders and Asians with kidney failure has tripled. And I don't quite understand that number yet, and no one's really explained it to me, but it's a little worrisome. And for Hispanics, we do know that they're more likely to develop end-stage kidney disease because of diabetes. And we know that it's very, very prominent and common in the Hispanic community. Other facts, at the end of 2020, we have 13.7% of all patients on dialysis performing it at home, and we call this home hemodialysis. Now, what's the big deal about home hemodialysis? We know that patients do better. I'm going to go to the other screen real quick, but this is a really, really small number of patients who are doing home dialysis. And what's really startling is that this is a 50% increase for this period of time 2010 to over this 10-year period, we've doubled the amount of people receiving home dialysis, but now that number is up to 13.7%. I'm going to go to home hemodialysis. The reason why now there's a big push for home dialysis, and this is whether it's dialysis, either daily or nocturnal, meaning like it's the type you get at the in-center, but you're doing it at home, or peritoneal dialysis, which is a form of dialysis where you have a catheter in the belly and you do exchanges with a machine at home. You get training on how to use the machine, but this also you do at home. So these are forms of home dialysis. Now, the reason why there's this big push is because, first of all, we know that patients do better. They take less medication to control their blood pressure. The anemia is almost gone in terms of requiring support to maintain their blood counts. It keeps their phosphorus under better control. So we know that patients who are on home dialysis, whether it's PD or doing their daily or nocturnal dialysis at home, they don't even need binders. While if you do the regular intermittent dialysis where you go to the center, most patients are going to need to take binders to bind the phosphorus. And they were talking about the calcium and phosphorus, that's what causes the calcification. So the phosphate is kind of the driver there. But people who do home dialysis tend to not even require any binders, right? And we also know that people who perform home dialysis at home tend to have less of the neuropathy, which is that numbness and tingling, or the restless leg syndrome that some of our patients can have. And we also know the reason why I think people are so fearful of dialysis, they say, man, my uncle had dialysis, and after he gets his treatment, he just feels so poorly afterwards. And so we call it that washed out feeling. But we know that when you do home dialysis, whether it's home hemodialysis or peritoneal dialysis, people tend to feel better. So they don't have that washed out feeling after their treatments. They have more energy to do their daily tasks. They sleep better. They have apparently fewer and shorter hospital stays. And of course, a better quality of life is often reported. I'm going to go back to the previous slide. Talking about among patients with end-stage kidney disease, right here, who were waitlisted for a kidney transplant in 2015, 55.7% received a kidney transplant by the end of 5 years. So people often ask me, what's the average waiting time for a kidney transplant? It is about 3 to 5 years, but even at 5 years, you see only half the people who are waiting for a transplant or have been transplanted. And for children, of course, it's much better because they have their higher priority. So by 5 years, 92.9% of them have been transplanted. And it also, of course, depends on the age bracket. Women were more likely to receive a kidney transplant by 5 years versus men, but only slightly. And white Americans were more likely to receive a transplant by 5 years versus Blacks or Hispanics and Asians, which is around 50%, and Native Americans and Native Hawaiian Pacific Islanders around 40%. Go forward. All right, just to give you some idea about what chronic kidney disease looks like in Maryland. Living with chronic kidney disease in Maryland, there are greater than 721,000 adults, and 82,000 adults in DC that are living with chronic kidney disease, meaning reduced kidney function. Of these, 635,000 and 72,000 in DC remain undiagnosed. Just bringing out the point that most people who have chronic kidney disease do not know that they have it. Remember that slide that said most people do not have any symptoms. How you know that something's not quite right with your kidneys is getting that blood test and getting that urine test done. Greater than 18,000 Marylanders are living with end-stage renal disease without treatment, of course, meaning dialysis or transplant. End-stage kidney disease is fatal, meaning you cannot live without your kidneys. 2,300 Marylanders are waiting for a kidney transplant, and over 11,000 depend on dialysis to stay alive. I do have some recent data. I think I put it here. Yes, in 2022, in terms of kidney transplants, 25,499 kidney transplants were completed in the U.S. And as of February, there were still 88,658 people who were still on the wait list for a kidney transplant in the U.S. So that's a little bit, this is a little older data. So this is the most recent data in 2022. Prevalence of chronic kidney disease. Unfortunately, some groups are more likely than others to develop kidney disease, specifically minority populations, as I've told you about, Black or African Americans, Hispanics, Latinos, Native Americans, Alaska Natives, Asian Americans, and Native Hawaiians or other Pacific Islanders are increased risk for developing chronic kidney disease. mainly because these populations have higher rates of these risk factors, which is what I'm going to talk about next. And I call them modifiable risk factors because these are things that the patients can do to help in terms of slowing their progression for chronic kidney disease, no matter what the cause is, right? Outside of medications, there are some things that people can do to slow the decline of kidney disease. Risk factors for chronic kidney disease in adults: diabetes is number one, of course, hypertension, number two, heart disease, obesity. Not a whole lot you can do about your family history of chronic kidney disease, but it is a risk factor for chronic kidney disease. And now we know that there's a genetic risk. We've always known about sickle cell disease tends to lead to chronic kidney disease and kidney failure. But there's another gene that we are actually screening for now. I don't know if patients have had this tested, but it's called APOL1. And there are a couple of, well, there are two that we look at specifically. These are two risk alleles. And depending on if you have them, it can determine if you're at increased risk for getting kidney disease and also increased risk for progression. And I can tell you I'm doing more genetic testing, maybe because I was familiar with genetic testing when I was at Maryland, but I do look for this. We do genetic testing. We partner with a company that is looking at this as well. And I'm finding that a lot of my patients are carriers for this APOL1 risk allele, APOL1 gene. And what that means, if you're a carrier, you can pass that off onto your children. So they should also. So I do a lot of counseling in terms of my patients, because of course, if you're with me, you have chronic kidney disease. But if they also have the gene, whether it's just one of the genes or both genes. So one gene will be a heterozygous. When you get two copies of that gene, you are homozygous. And we know that patients who get two copies who are homozygous are at increased risk for chronic kidney disease and progression onto end-stage kidney disease, renal failure. So I'm doing genetic testing just because I want to know what I'm looking like 10 years down the road for this patient, right? And I can tell you I have these are 40-something-year-old Black men who are both homozygous for APOL1, who went from relatively stage 3 to stage 5 in a period of 4 years on average. And so that is because this gene increases your risk for progression. And now they had some modifiable risk factors, which we'll talk about, which I felt weren't adequately addressed before they came to see me. But this having this gene or these risk alleles did put them at risk for progression. And for children, when we talk about chronic kidney disease, these are usually congenital causes for chronic kidney disease, genetic disorders, and of course, kidney infections if they have some issues with their urinary tract. But it is true, anyone can develop chronic kidney disease at any age. And I actually have a couple of people who have two types of kidney diseases, so it's possible to have more than one. Now, the real problem in terms of increased risk factors leading to increased risk is that when we look at disparities, we know that nearly 45% of Black men and 46% of Black women have hypertension. And I think this number is actually much higher versus whites, which is around 33% and 30% in women, respectively. The prevalence of diabetes is about 13.2% in Black Americans versus 7.6% in white Americans. And the proportion of chronic kidney disease due to diabetes or hypertension is up to 12-fold higher in Black Americans versus white Americans. Black Americans tend to develop hypertension at younger ages, possibly due to some genetic risk alleles. I'm sorry?
I'm trying to not figure out how is the best way to tell you I have questions in the chat. So if you, wherever
Go
you want
ahead.
to stop when I do
Let me
that.
okay, give me 1 minute. Let me just finish about obesity. Obesity, we know, is a risk factor for kidney disease, 48% versus 33%, and may increase the risk for CKD progression, and it also increases the risk for diabetes and hypertension. All right, Patty, we can address some questions. I'll take a break.
Perfect, thank you. Carolyn asked, what is the average lifespan of a transplanted kidney?
So we know that living donor kidney transplants last a lot longer than deceased donor kidney transplants. So on average, about 10 to 15 years, right? Living donors can last a lot longer. Actually, I just saw there was a report where I'm not sure who she got her kidneys from, but 50 years. That's the longest I've heard for a living donor kidney transplant. But I
That's
have to,
amazing.
it is amazing. But I personally have seen people who have had living donor kidney transplant 20 years plus out, right? So ideally, and we'll talk about this later, if you're going to get a kidney transplant, you would preferably get a living donor kidney transplant versus a deceased donor kidney transplant, right? But if that's not available, of course, a deceased donor kidney transplant. And it also depends on a number of factors. It depends on your match. If you're a good match, we know that even deceased kidney donors don't donated kidney transplant. If it's a perfect match, those kidneys last longer, right? And it also depends on the recipient too, which we'll talk about later. But yeah, so on average, about 10 to 15 years, depending on some factors that we'll cover a little bit later. Perfectly matched deceased donor kidney can last quite a while, about 10 to 15 years. But ideally, you want to see if you can get a living donor transplant, right? And we do need to kind of increase that conversation because patients, I'm not even sure that patients know that what you really want is a living donor. And I do tell my patients, are there any family members that are healthy that can donate a kidney because that gives you the best chance of having a long life with that kidney transplant, right? Versus a
And
deceased.
that's a great segue too. I dropped in the chat about our upcoming Big Ask Big Give Living Donor Workshop that's in partnership with University of Maryland Medical Center. It's free to the individual who's interested in a kidney as well as a caregiver. And it is a free lunch and free parking. And so all the details are in that drop link that I gave, the information I gave. And then Dan also had a question or a request. Can you
Sure.
talk about CKD due to transplant drugs such as, and I'm not going to say this right, TACROLIMUS, you
Yeah,
know,
that
I
yeah,
have
that's right.
developed CKD3 after after lung transplant. So can you talk
Yeah.
about the drugs and transplant and that?
Right. So, the immunosuppressives that we use, and that medication is called tacrolimus or Prograf, right? So that is one of the main immunosuppressants that we give our patients when they have any kind of transplant. So this person has a lung transplant, but kidney transplant patients, right, are started on these medications. It is a fine line that you walk when you're on these medicines and this is why we check levels for those medications, right? Because we know that people who are on tacrolimus or Prograf or cyclosporin, which is the other medication that most kidney transplants patients are taking, they're also what we call nephrotoxic, right? They can actually cause scarring in the kidneys, right? So this is why we watch levels very carefully. These medicines, it's kind of like the ACE inhibitors, where these are the medicines for blood pressure to control your blood pressure, but we also know they can be harmful too, and they can cause problems. So there's a fine line that we walk when we talk about these medications, the immunosuppressions that the immunosuppressants we use for to keep the person who gets a transplant from rejecting, but they also have side effects and they're harmful side effects. And so, like for my patients back in the day when they were on Prograf or tacrolimus, and we saw that there were signs of scarring in the kidneys related to the medication, meaning that they were causing some loss of function, chronic kidney disease is what he said, that we would back off on that medication a little bit or try to find an alternative if there's something available to take its place. But yes, these medications, there's always good and bad with these medicines. I mean, you need these medications to prevent you from rejecting your allograft or your transplant. But in the same sentence too, these medications have a lot of side effects associated with them, right? So yeah, they're always working on trying to find better medications. And they're looking and trying to find better medicines to, prevent patients from rejecting and still not cause these horrible side effects as associated with these medicines. Yeah. So it's tough. It's not easy. And we have patients who are on Prograf who don't have, our transplants, right? And we are always thinking about, is it causing the scarring? Are they developing chronic kidney disease because they're on this medicine to treat another disease that they have, right? It's just part of the side effects. It's not easy, but it is a balancing act. So yes, unfortunately, there's no good answer for that, but these are the only medicines that we have right now to use. I'm hoping in the future, as research finds newer drugs that'll be very good in terms of immunosuppression, but don't have all these nephrotoxic side effects associated with them.
Thank you.
Mhm. Anything else, Pat?
So Harold noted that another major anti-rejection medication is mycophenolate.
Mycophenolate, that's salsa.
Yeah.
Mm-hmm.
And Chris noted everolimus. I'm not a doctor, folks. I don't play
Mm-hmm.
one on TV, so my apologies.
Uh-huh. Uh-huh. Yeah. Uh-huh.
Yeah. And oh,
Yes.
that's the question. And then
Mm.
can you talk about getting a kidney with a pancreas and how it shortens the wait list?
Oh, absolutely. Yeah. So I actually have a couple of my patients. These are diabetic patients, right? That would be the only reason to need a pancreas transplant. So, and these are patients with type 1 diabetes who are, when you need two organs, that moves you ahead on the wait list, because you're going to get those two organs from the same donor, right? Because you don't want to get a pancreas from one person and a kidney from another person, and that can increase your risk for rejection, by the way, because it would be a mess. So yeah, so because you need those two organs, push that raises that actually factors into the calculation of where you're going to be on the wait list. Yeah, so because you want those two organs to come from the same donor. And then about the other medications, yes, Cellcept and everolimus, yeah, they're supposed to be a little more kidney friendly, but normally patients are on these medicines in addition to Prograf or cyclosporin. It just depends on the regimen that the transplant center chooses at that time for that particular patient, right? So most of our patients, when I was at Maryland, most of our patients were either on Prograf, tacrolimus, or cyclosporin, and Cellcept or mycophenolate, and prednisone. And then we decided that was a little too much, so most patients are now just on Prograf and Cellcept, or cyclosporin and Cellcept. Everolimus we would use in certain cases, and Rapamune in certain cases. Yeah. But yeah, there all these medicines, all the transplant medications, the immunosuppressants, they all have side effects associated with them. But your transplant service and your transplant doctor are watching for these side effects too.
So we'll allow Dr. Cunningham to continue her presentation. There are a few more questions, but at least I'll hold them until
Okay.
you're through a
Sounds
few
good.
more there. Thank you.
Okay. Let's continue. Alrighty, so I put here, the fear of God is the beginning of wisdom, and that's Proverbs 9, 10, and 11. The reason why I bring this up, because I think, why do we get into trouble in the first place with chronic kidney disease? If you don't have an intrinsic kidney disease, most of chronic kidney disease that we see, and I told you before that the most common cause of chronic kidney disease in this country, diabetes is number one and hypertension is number two, right? These are modifiable to some extent, meaning I often see patients who come to me, usually they're probably at stage 3 by the time they get referred to me, but their diabetes is out of control, right? They have been with primary care for quite a while, and by the time they get to see me, there's evidence of kidney damage, meaning either they have a reduced eGFR, the GFR has dropped, or they're spilling a lot of protein in the urine, the sign of kidney damage, as we talked about before. So by the time the patient gets to me, they already have evidence of significant kidney damage, right? And poorly controlled diabetes. So these are the things we need to work on first. Before you get to me, we need to work on getting better control of the diabetes and hypertension, getting control of the obesity, weight loss. You'd be surprised what weight loss can do. I have a patient right now, she has lupus, actually. Oh, and her lupus is very difficult to control. At one time, we had her on 5 medications, including Prograf and Cellcept that we talked about recently. And her lupus was she was spilling a lot of protein. It was just out of control. But she was significantly overweight, and she just had the gastric sleeve procedure, and her proteinuria has been cut in half. So we don't quite understand the physiology between obesity and chronic kidney disease, but there's a clear relationship that obesity can cause kidney disease. And normally we see this with what we call FSGS, which we'll see some scarring in the kidneys when we do their biopsy. And these patients are usually spilling protein. It's kind of what happened to her. Now that she's lost a significant amount of weight, we're seeing less proteinuria in the urine, and her kidney function is actually okay already. But I think in general that just because she's lost the weight, we're going to see a slower progression of chronic kidney disease. Now, other modifiable risk factors, hyperlipidemia, high cholesterol, and this is important when we talk about cardiovascular disease. Remember what I said before at the very beginning, chronic kidney disease patients, they don't die from chronic renal failure, right? They die from heart disease, and we're going to talk about that shortly. And then, okay, yeah, the uremic milieu was what one of the I think one of the participants was asking me about calcium and phosphate calcification. phosphate, yeah, that can make it difficult in terms of heart disease, anemia. In the old days when we didn't have medications to keep the blood count up, you can actually go into congestive heart failure with anemia, with severe anemia can lead to congestive heart failure, and then volume changes. That's always very hard, and that goes along with progressive kidney disease and kidney failure. Now, most common causes of death in patients with chronic kidney disease, number one, cardiovascular death. And this is why I harp on this so much with my patients. When my patients come in to see me and they have risk factors that are not well controlled, their diabetes is not well controlled, their blood pressure is not well controlled, they're obese or even morbidly obese. These are the things I work on with my patients, actually. I work on getting their diabetes under better control, and I can tell you I'm very successful at it. By the time they reach me, I would say 90% of my patients have their diabetes under control. Now, it's kind of sad though, because I told you they're actually usually late referrals, right? So by the time they get to see me, they have a lot of damage. And then what's really disheartening is that they'll ask me, well, why isn't my kidney function getting better? And I have to tell them it's not because, what you're doing right now. You've been with me for a year or two, but it's kind of what had been going on 10 years down the road, right? 10 years ago, when your hemoglobin A1C was running in the teens, that's when the damage was accruing, and that damage becomes chronic. That's why it's called chronic kidney disease, and it's not reversible, right? What we're doing at that point, by getting our diabetes under control, is slowing progression, meaning we're trying to prevent diabetes from causing further damage, right? And that delays that loss of kidney function over time. I tell them we're changing the slope of loss here. I can't go backwards, but we can kind of change that slope a little bit so that, we slow things down. Same thing with high blood pressure. What I tell my patients, I have patients who I do get referred early with diabetes, and they get their diabetes under control, right? And I see any evidence of proteinuria, if they had low-grade proteinuria, that goes away, right? When you get your diabetes, that's early in the course of disease, right? If you get your diabetes under really good control, we see improvement. I see improvement in kidney function just with improved diabetes control. This is early, not late. Hypertension is different though. My patients who have hypertensive kidney disease as a cause of their chronic kidney disease, that hypertension it causes a lot of scarring and damage in the kidneys. And the reason why it does that, I tell people, think of the kidneys as a bunch of small blood vessels, right? Millions and millions and millions of blood vessels, right? Okay, thousands, hundreds of thousands. But they're small and they're tiny. The walls of the blood vessels are like tissue, paper thin, right? So what does hypertension do? Hypertension puts stress on the wall of the blood vessels. So they thicken up and they get sclerotic. There's a lot of fibrosis, right? So hypertensive kidney disease, even if I get their blood pressure under control, I don't see reversal of the kidney disease, right? And that's if it's been going on for a while. Usually it has been by the time they get to see me. Remember, by the time I get referred patients, they're usually at the stage 3. And I can get their blood pressure under control. It's really rare that I can't get somebody's blood. If they are working with me, if it's a partnership, we're working together, I can get people's blood pressure under control, right? But I can't get that function back, right? Because remember what I said, it's tissue paper. The vessels are really like tissue, like fine tissue. And by the time high blood pressure causes that damage, it's all thickened, it's fibrosed, it's scarring. You get loss of healthy kidney tissue, and loss of function as a result, right? Obesity, as I told you, there's scarring in the kidney. It's a little different, and we can see improvement in the kidney function if patients lose weight. Hyperlipidemia, the reason why that's there is because it's a risk factor for heart disease. And as I told you before, heart disease is the number one cause of death in patients with chronic kidney disease in this country. And then I'll go on that a little further. Cancer is 31. Now, if you're saying, does chronic kidney disease cause cancer? I don't know if that's necessarily that kind of relationship. I just think that people with chronic kidney disease tend to smoke. Smoking is associated with certain cancers, and that's where that risk comes in. But it's interesting that there's a high risk of cancers in patients with chronic kidney disease, pulmonary disease, as I told you about smoking, diabetes, and these are probably like people with complications of diabetes. NS means nephrotic syndrome. That's a type of kidney disease that causes a lot of wasting of the protein. Nephritis it's a type of kidney disease that causes blood to show up in the urine. So these are probably complications related to these diseases. Alzheimer's, we see that a lot in our patients, and People, when they have toxins that build up in the bloodstream, it can cause altered mental status. And I don't know if the relationship is a direct relationship, but we do see Alzheimer's and complications of that leading to death in patients with chronic kidney disease infection, the flu and pneumonia. What people don't know is that I'm talking about people with progressive chronic kidney disease or in that stage 4 or 5 category. Chronic kidney disease, it kind of alters the immune system. So your immune system is not quite normal. And this is what we saw with COVID, actually. People with chronic kidney disease were at increased risk for COVID, serious COVID illness. And, we were encouraging patients to get vaccinated because of that fact. The immune system just doesn't, it's not as strong, it's not as healthy. It's kind of like an older person who has a difficulty fighting off infections, right? Elderly were at increased risk for serious COVID illness. Same thing with chronic kidney disease because the immune system is not quite normal or quite healthy. And then liver disease is a very small portion of those patients. When we talk about cardiovascular disease, we're talking about heart disease, and that's the kind where you get blockages in the heart, right? And it leads to a heart attack or myocardial infarction. But I have to talk to you about this next session here. It's called congestive heart failure. I would say about 30 years ago when I was 20 to 30 years ago when I was at University of Maryland, the number one cause of heart disease was this coronary artery disease and myocardial. I mean, people were having heart attacks because of blockages, right? Nowadays, it's congestive heart failure, especially for chronic kidney disease patients. And I think this goes hand in hand with hypertension. In Black folks, we know that the most common cause of congestive heart failure is due to hypertensive heart disease, right? Leading to congestive heart failure. And that's actually, and I don't know if people who are on the line right now, if they have a history of congestive heart failure, it's more likely to be due to diastolic dysfunction. And what does diastolic dysfunction mean? It means you've had hypertension and the heart is thickened up, right? So the heart doesn't, it's not that it doesn't pump well, it's actually it's pumping too well. So blood's not flowing forward, it's flowing backwards. So it's a little hyperdynamic. And so patients with diastolic heart disease tend to have ejection fraction, which is the percentage of how your heart's beating, that are on the high side, not the low side. So the low side is what we see normally with coronary artery disease and people who've had heart attacks. The high side is what we see with people who have diastolic dysfunction, hypertensive heart disease, and they can get congestive heart failure. And that's actually the number one cause right now of death in our patients from heart disease and patients with chronic kidney disease is congestive heart failure is taking that number one spot. And then people have had strokes, of course. AFib is very common in patients with chronic kidney disease. Peripheral vascular disease is very common. And I brought this point up, sudden cardiac death. We tend to see this a lot in patients with end-stage kidney disease. I used to be at one of the dialysis units, and we'd have patients who just didn't show up. And we think they kind of fell into this category, which is actually not trivial. 5.5% of our patients are dying from sudden cardiac death, either a heart attack or an arrhythmia as the cause of a sudden cardiac death. And patients with chronic kidney disease are at 10 to 20 times greater risk of cardiac death versus those without. And as I told you, because of those risk factors that we talked about. Also, the risk of death from heart disease, cardiovascular disease, increases as CKD progresses. Meaning as your kidney function declines, the risk of cardiac death goes up. So how do we try to mitigate this, meaning heart disease being the cause of death for our chronic kidney disease patients? People have to know that they have chronic kidney disease and start working on these modifiable risk factors early versus late, right? Remember, you want to try to get tested to see if you have chronic kidney disease. Remember, we talked about it at the very beginning. Most people don't even know that they have chronic kidney disease. And I would tell my patients now, I was like, you know what? If I had chronic kidney disease, I would start working on my diet. My diet would be a pristine diet, right? Because we know what we eat affects us. It affects people who have diabetes know that when they don't eat the right foods, their diabetes will get worse, right? High blood pressure. We know that people who don't eat the right foods, they know their blood pressure will get up. I have a patient who has hypertension and he goes to have this. He says every week he and his friends get together and they go have seafood. And I'm like, okay, that's a salt load. Because right after, then he calls me and tells me his blood pressure is running high. He's like, my blood pressure is running high. And I was like, okay. All right, did you have a lot of seafood? That's a very high salt load. And African Americans, Black folks in this country tend to have salt-sensitive hypertension, meaning the more salt you take in, the higher your blood pressure. So these are modifiable things. These are things that people can do. People can work on at home. You don't even need me. And I have had patients who come to me and they tell me, Dr. Cunningham, I've been tested. They say I'm stage 2. My husband or I've had relatives who've had chronic kidney disease. I don't want to go down that road. What do you recommend? And what I tell them, go on a plant-based diet. Go on a heart-healthy plant-based diet. And the patients that have done that, of course, the number is very small, like 3. But my patients who have done that, they're not even, I can't even stage them anymore. So I don't know what if that just going to plant-based diet reverse their chronic kidney disease, but I can tell them that, your kidney function's a lot better. And I asked them, what did you do? And one of the ladies who did this, she's like, well, you told me to become a vegetarian, so I did. And I'm like, wow. But when usually when I mention that, people just kind of frown. But I do have a couple of people who've taken me up on it, and I can tell you that slope that we talked about, the loss of slope over time in terms of progression, kidney disease, it changes. Being on a plant-based diet or a vegetarian diet kind of changes the slope. I didn't tell you before though, but there's a natural aging of the kidneys. Kidneys are aging, right? Every organ in the body ages, so the kidneys age. You lose about a half a point to a point each year as you live. So I tell people, my 90-year-old grandmother, she, even though she's 90s, she still had a GFR of greater than 60. So she had normal kidney function. Remember, we start to worry when that GFR falls below 60. So my 90-year-old grandmother still had pretty good kidney function, right? She died from something else, but she didn't die from kidney failure, right? So normal kidney function, that's what you want to hold on to. And one way to do that is to change. These are lifestyle changes. I mean, when we say lifestyle changes, we really mean lifestyle changes. You really have to change what you're eating, how you're eating. I have a patient that this is just recent over the holidays. He actually has heart disease, so he has known heart disease. And I checked his cholesterol. It was 651. True story. 651 for total cholesterol. And I asked him, I'm like, okay, what are you eating? He's like, yeah, I know I'm not sticking to my diet. I was like, he has known heart disease. I was like, I've never seen cholesterol, this value this high. Call your cardiologist. But, he in his mind, and he's a nice guy. Actually, I love him to death, but he didn't see the importance of really changing his diet. And I know his cardiologist, if he saw those numbers, he would have heart palpitations. But I told him, talk to your cardiologist. These numbers are way too high. And this is Christmas holidays. I'm texting him, and I'm asking him, "Are you on a statin? You need a medication to get your cholesterol down." He said, "Yeah, Dr. Cunningham, I'm on a statin." I was like, "Are you taking it?" Because you got to take it first of all, and then talk to your cardiologist because there are other medicines that he's going to require to get his cholesterol under control. High cholesterol is a risk factor for heart disease. Remember, heart disease is the #1 killer. Patients with kidney disease. So you want to control these risk factors. This is a modifiable risk factor, meaning you can do something about it. Diet alone is very good in terms of controlling the cholesterol. I have patients who are vegetarians and their cholesterol is just not high because we know that if you're eating really healthy foods, healthy vegetables, there's not a whole lot of cholesterol in those foods, right? So most vegetarians tend to have low cholesterol. Okay, so I'll stop there. So get tested, please. If you don't know, get family members tested. Family history is a risk factor for having chronic kidney disease. Have your families get tested. And if you're able to, if you know that your family member has kidney disease and they've had genetic testing, that means then you should probably get genetic testing as well. And you would need to talk to your doctor about that. And also you can visit our website. I'm sorry, go ahead.
No, go ahead. Go ahead.
Oh, talking about visit our website. Do you want to see what your risk is? Go to minforyourkidneys.org and you can take the online. I did it actually. It was actually kind of fun. But you can actually assess your kidney health. And also the National Kidney Foundation offers free screening in the community, and go to kidneymd.org if you want to see when the next screening event is, or call for more information. Go ahead, Patty.
So in the moments that we have, this has been amazing. There are a few other questions
Okay.
that I can ask, but if it's okay too with Marty and Michelle, I can also get these questions answered and get them back to you too. But
Sure, that's fine.
here's a couple other things just
Okay.
because people were asking.
Sure.
Again, a lot good kudos about what information you're providing, particularly around weight control.
Mm-hmm.
But what are ways to improve proteinuria?
Yeah.
I get it
Mm-hmm.
out.
Uh-huh. Yep. Protein in the urine. So there are medications. First of all, if you've been shown to have protein in the urine, and I do like for my patients to be on these medications. First of all, it's called an ACE inhibitor or an angiotensin receptor blocker. Most patients who have protein in the urine, this can be started by your primary care provider even before you get to see me. So you've heard of these medications: lisinopril, Acupril, benazepril, all the prils. I tell patients, are you on a pril? It ends with the pril. So those are medicines that we know help reduce proteinuria, right? In patients with chronic kidney disease, whether you're diabetes or hypertensive, doesn't really matter. Um, and then the other medications, so some people are allergic to those medications, meaning they just can't take them because they've had an allergic reaction or whatever. Then the angiotensin receptor blockers, so these are the sartans. This is what I tell people. Are you on a sartan, losartan, valsartan, irbesartan? Those are the cousins to the ACE inhibitors, right? And they're also good in terms of proteinuria reduction, reducing the amount of protein in the urine, right? We tend to think less protein means better outcome for patients with chronic kidney disease, right? Versus a lot of protein in the urine. After that, we have new drugs now that we use, especially patients who have diabetes, and these are the SGLT2 inhibitors. So these are medications, you've seen the commercials, Farxiga, Giardians, and Vocana. These are medicines that also help to decrease their proteinuria, usually about a third, 30% reduction in proteinuria. And there are other medications that are in the pipeline also to reduce their proteinuria. But yeah, the goal is patients with chronic kidney disease who do have proteinuria, we want to reduce that proteinuria. And they're pretty good. Some are very good about it. I've had patients who have diabetes who like were started on either Farxiga or Giardians, and I've seen maybe 50% reduction on top of the ACE or the ARB, a reduction in proteinuria. And they also work to get their diabetes under control. But man, it was just remarkable. So 20 years ago, we didn't have Giardians, Farxiga, and Vocana. So these are add-on medications, so the ACE and the ARB, in terms of helping to help stabilize, tighten the kidney function. So these medicines we know change the slope, right? So they've lost the kidney function over time, and they reduce their proteinuria. So they have kind of a twofold effect on your kidney disease, and hopefully it's going to slow things down. So once you have chronic kidney disease, like for example, when you get to me, you're stage 3, my job at that point is to slow things down. Remember what I said, usually things have been going on for a long time. Now, if I get you early, we can actually stop that. We can stop a lot of it, by the way, right? But if I get you late, this is what I'm looking at. I'm looking at medications to slow the loss of function over time, reduce the proteinuria, kind of stabilize the kidney function. And if we're successful, we can do that for quite a while, by the way. And then it depends on what's the cause of the kidney disease. Some kidney diseases are treatable or curable, by the way, right? Others we just treat. So right now, for some reason, I have a rash of IgA patients, and these are patients that have. We're not quite sure the cause of it, but these are patients that have. This is a true kidney disease, right? And there are now new medicines for IgA nephropathy, and they cause it. And some patients who have poor prognosis, meaning they're spilling a lot of protein, we put them on these medications and we see a reduction in proteinuria, and hopefully will slow the loss of function of kidney function over time in those patients. So yes, reducing the proteinuria is very important in their medications, and make sure that you've been offered these medicines if you have chronic kidney disease and you're spilling protein in the urine, especially.
Okay, thank you for that. Why is there a disparity for Black kidney patients versus other nationalities? What is the final determining factor before being considered for a transplant?
Okay. Yeah, so a couple of things, and we'll get to it a little bit later we may be done. I'm so sorry about that. But there are a couple of reasons. I think African Americans tend to have more diabetes and more hypertension, so we have more of those risk factors. There's the genetic risk that I told you about. There's an APOL1 gene that can kind of put us at increased risk. You can't do anything about your genes, right? I like to know just to know what I'm dealing with. Maybe I am a little bit more aggressive, but so there's that genetic risk, which you can't fight. But you can do something about these modifiable risk factors. You really have to do lifestyle changes. And if that doesn't do it, medications, right? Not only just being started on these medicines, the ACE, the ARB, the SGLT2 inhibitors, but people are started on them and then they're kind of not reassessed. Are they doing what they're supposed to be doing, right? Are you getting the benefit? If you're not getting the benefit, you go back and you make changes. And that's what I find that in terms of minorities, people tend to sit on certain ethnic groups, meaning they're not as aggressive, right? So of course I'm very aggressive, but I find that, if your blood pressure is still not to goal, so if you have diabetic kidney disease and you're spilling protein in the urine, your goal blood pressure should be less than 130/80, right? I have a lot of people that come to me and they're not at goal, and they've kind of been just kind of sitting on it, right? But no, you should, if you're taking medicines for your blood pressure, you might as well get to goal, right? So, and we know lower blood pressure is better on the kidneys versus higher blood pressure, right? We know we tend to, and we've studied this though, we know people who have lower blood pressure and they have proteinuria and diabetic kidney disease, they tend to do better at these lower goals than if your blood pressure is running higher. Same thing with hypertensive kidney disease. I'm sorry, my phone is ringing. The goal blood pressure should be less than 140/90. And if you have protein, less than 130/80. But I tend, it's kind of an inertia, meaning we don't do what we're supposed to do, and that's on clinicians, right? Clinicians, we're part of the partnership, right? But if we don't have you at goal, we need to keep working until we get you at goal. So that's what I feel some of that comes from. We can't fix our genes, right? But also I find that we don't ask the right questions. So when family members come to me, I'm like, what did you ask your doctor? Oh, I didn't ask him anything. When you go see your doctor, I'm not offended. If someone comes in with paper and pad and they have questions, I'm not offended at all. I want you to ask because, that's kind of what that visit is about. Ask those questions. So you have to be armed. You need to go in there and saying, I've looked at my numbers, and I ask my patients sometimes, do you know what your last hemoglobin A1C was? A lot of them look at me and say, no. I was like, but you got to know your numbers. This is how we impact your health, right? If you get control of these modifiable risk factors, right? Trust me, it changes the slope, right? This is what we can do at this point. We want to change the slope of loss of kidney function over time, but you got to get your modifiable risk factors under control. Don't sit on them. If you're not at goal, if your blood pressure is still poorly controlled, don't sit on it. And months and months, years later, I got a patient who I was seeing. She stopped seeing me for a couple of years. I mean, she had advanced kidney disease when she came to me, but when she came back, she was at stage 5. It was a shock, right? Because remember what I told you, it doesn't hurt to have kidney disease, right? And I don't know what kind of care she received in the interim, but what I do know is no one talked to her about her kidneys, right? So go into your doctor's office and be prepared. Be prepared with your questions. Ask them, am I at a good place right now with my diabetes, with my blood pressure, with my cholesterol? These are modifiable risk factors. They affect you. Remember, our kidney patients don't die from kidney failure. They die from heart disease, right? Heart attack, stroke, congestive heart failure, right? So those are things. So that could be one of the reasons. And sometimes I think if you don't ask questions, doctors get the impression that maybe you're not all that interested. And I know that sounds kind of horrible, but then they're not going to be pushing you. Now, if you ask questions, that pushes us. And I tell people, because I remember one time I had an accountant come to me. Mind you, he's an accountant. He likes numbers. He came to me with stage 3 kidney disease. He said, nobody ever said anything to me about it. He's like, and I'm like, well, did you get your annual physicals? Yeah. I was like, ask questions, right? Say, doc, how are my kidneys doing? Right? So then that changes their focus. They'll tell you, oh, your creatinine is this, and you're at stage this, right? So, but if you don't ask anything, they'll say, oh, it's fine, because it hasn't changed over the past year, right? So you want to go in there, you want to be specific in your questions, right? You want to be your own advocate when you go there, or bring somebody with you. Because I tell patients, if they're elderly, and sometimes you just don't hear it, but that other person may hear it, and they may come with questions, or they may say, well, didn't you hear that she said this? So I tell, especially my elderly folks, don't come alone. Come with somebody. Bring somebody in with you. So maybe when you don't hear it, maybe they hear it, right? And or not, but it's always better to come with somebody and to come to the office prepared, because you're more likely to get more feedback, right? And remember, this impacts your health over time. So
Thank you, Dr. Cunningham. You give
Mhm.
such amazing, you're very passionate about your responses, and we appreciate that. In our final moments, we're going to try to
Sure.
answer the rest of the questions that we have.
Okay.
What are the symptoms of someone developing heart disease?
Mm-hmm. Mm-hmm. So, so you don't know that you have a heart attack until you have it, right? So symptom wise, you're not going to feel anything until, so what your question should be is, what are the risk factors that lead to heart disease, right? Can't fight your genes. Some people I have patients who have extremely high cholesterol. And that could be that patient I told you about, because I didn't really ask about his family history. But I can tell you, I've been practicing medicine for over 25 years, almost 30 years. I've never seen a total cholesterol that high. So that speaks to me that he's got some kind of genetic issue with cholesterol metabolism, right? And that comes from so, and that's usually you'll see like, oh, my dad died when he was like, 50, or I have uncles that didn't make it past 50. So that kind of screams there's some family history and some genetic kind of predisposition for high cholesterol. But so you're not gonna know what your heart disease, if you have heart disease, unless you get a stress test, right? Right? Or a cardiac cath, and that'll tell you. And even that too, sometimes, or people now are doing calcium scores, although I don't find those too reliable, meaning you get a CT scan and it looks at your calcium scores, and that's supposed to risk stratify you. But I tell you, you want to work on these modifiable risks, right? If you want to prevent yourself from having heart disease, get your diabetes under control, make sure your blood pressure is controlled, you're eating healthy, make sure your cholesterol is controlled. These things will prevent you from having heart disease.
Great advice, Dr. Cunningham. A question is, do you as a vegetarian have to watch your potassium levels instead of salt?
So yeah, so for chronic kidney disease patients, there are some patients that will have trouble with potassium, and that's a good point, actually. So I do have patients, especially diabetic patients, that tend to run higher potassiums, and so even if they eat like more vegetables, they have to watch the foods that they eat. They can't eat foods that are high in potassium. So that's challenging, but not impossible, because I give them lists and I tell them how much potassium they can have in a 24-hour period, and you can still have a pretty decent diet on lower potassium foods. But not everybody with kidney disease, especially if you're early stage, my patient did get kind of carried away. You don't really have to watch potassium if you're able to manage the potassium. So if you don't run a high potassium, then you don't really have to be on a low potassium diet. Just be on an average potassium diet, right? And then your doctor will let you know for sure, because they'll be checking your potassium. But I find people that are in stage 1, stage 2, even stage 3s, if they're not diabetic and tend to run high potassium, they really don't have to be on a low potassium diet, because potassium is really, and we know this now, that people who are on potassium rich diets, it's really good for the blood pressure, and some other things. So I hate really restricting potassium in the diet unless unless my patients with chronic kidney disease are running a high potassium. That's the only time that I really restrict it. If they're not running a high potassium, I let them eat, and then I'll see if they have to cut back or not. But I don't really restrict it if they don't run. Now I know my patients. I know it's very clear who runs a high potassium. It's very clear. So for those patients, I do put them on a low potassium diet, but I make sure that it's still really. And we talk about it. Actually, we talk about you can still have this even though you can't have this, right? So we talk about how still to maintain a healthy diet on a lower potassium diet. It's possible.
Thank you. How does coffee impact kidney before and after transplant?
Okay, so here's the problem with coffee. People ask the same thing about alcohol. I don't take away alcohol if you want to have a glass of wine with your meals. No, you have to be careful, but I don't take away caffeinated drinks unless, right, you're on like a diuretic, you have congestive heart failure. Remember, caffeine is a natural diuretic, right? So I have a patient right now, she can't have any teas right now because she's already dehydrated, right? So she has heart disease and she was on high dose diuretic. And I'm trying to give her a little bit of time off of her diuretic. So no, I don't want her drinking caffeinated drinks if I'm trying to kind of hydrate her gently because of her heart disease, right? So yeah, so depending on your hydration status, right? Caffeine is even alcohol is very hydrating, right? Dehydrating, I'm sorry. So you don't want to do a lot of caffeinated drinks if hydration is an issue, right? So I tell people, unless you absolutely just be careful with your caffeine intake, right? And same thing with alcohol, everything in moderation. So patient will ask me, well, can I have a beer? As long as they're not drinking 6 beers. I let them have their beer. Or can I have a glass of wine with meals? Yes, you can. Be careful with your medications, of course. But yes, I don't take your wine away, your glass of wine away with dinner. You just be careful. Remember, everything in moderation.
Yep. There are some great comments in the chat that I'm sure everybody's been reading, just reinforcing what you're saying and or giving their own experiences. So I do hope that everyone is reading those messages. So I think a final question here is, do you recommend fasting 8, 12 hours? Do you recommend fasting at all? in the process.
Yeah, that's hard because, kidney disease patients, they can become malnourished, right? So I don't know if I necessarily recommend fasting, especially for my diabetic patients or for my chronic kidney disease patients. I really do recommend just a healthy diet, actually. And I do fast. I fast, but I actually fast for religious reasons. But if there's some patients that want to fast, for whatever reason, I guess I'm not completely against it, but they do have to be careful. They really do. Yeah, because fasting really does change your physiology, by the way, right? You go into ketosis when you're not eating. And that could be an issue, especially if you're taking some of the medications, and especially is the SGLT2 inhibitors, because those patients can go into ketoacidosis, right? Just because of the medication itself. So if you're fasting, you go into ketosis. That's difficult, right? So that's one of the reasons why I really don't like fasting, because it really does change your physiology. But I don't know if I'm completely against it in terms of weight loss. But I do tell my patient, in terms of weight loss, if you're morbidly obese, I'm okay with doing the gastric procedures because I've seen it just work miracles in some folks. People who are diabetic or no longer diabetic after they have their gastric bypass or sleeve, people who are hypertensive, their blood pressure comes down, they come off their medication. So yeah, it's challenging, but you should have these conversations with your doctor to see what would be the best route for you in terms of weight loss. There was something about the kidney transplant. I did have a section on it. I'm sorry, I'm not going to be able to reach it. But in terms of Blacks not being referred for kidney transplant, we don't know why that is. Somehow it may be part of that physician inertia, where physicians, when we offer, I offer, I have to tell you, anyone who has a GFR of 20 or below, I offer kidney transplants to everybody. Like, we talk about it, we have the conversation, right? But it's one of the studies that I did look at. They were saying that if African American expressed kind of not much interest, then the physician would kind of leave it and wouldn't come back to it. So, but I always leave that door open. But that could be one of the reasons for late referrals or less referrals for African Americans in terms of kidney transplantation.
Thank
And
you,
other
Dr.
ethnic
Cunningham.
Mhm.
Yeah. On behalf of the National Kidney Foundation, we really want to thank TRIO for having us. We will make sure that the presentation is posted. The video I know you will get. I wish we had more time to go on and on. Someone said, please do another presentation, Dr. Cunningham. So keep watching Kidney .org, kidneymd.org for latest information, and watch our social media channels because we do post a lot of great things. And I did post about 2 upcoming conferences for patients and their caregivers, March the 17th and April the 14th. Great opportunities for you and caregivers to come spread the word. We love to have people there. We have amazing doctors like Dr. Cunningham present to do this. So thank you. And someone said it best in the chat too, be your own advocate. That's how you make a difference for your own health. Health is wealth. So again, thank you, Dr. Cunningham, for your excellent presentation.
You're welcome.
Thank you, Dr. Cunningham. It was
You're welcome.
so informative, and you explained everything very well. I think that's why everyone is so delighted with your presentation, because they understood everything. So that's just fabulous. We thank you for your time.
You're welcome.
You have a lot of fans. I don't know if they're going to start stalking you now, but if there's a problem, let us know, because you have many fans there in the chat room.
No problem. And I'm always available if anyone has questions, of course.
Thank you
You're
all.
welcome.
And I wanted to thank everybody else for attending today. We love to see your smiling faces. Don't forget to check out our events page on our website for advance notices of our future meetings. Check out our website, www.triomaryland.org, for all of our past meetings are posted to our YouTube channel for your convenience. And don't forget to get out and volunteer in April. And the last thing I'd like to tell you about before we leave today is, for your information, TRIO Maryland will be hosting its 3rd virtual transplant conference on Saturday, May the 18th. So look for details on how to register in April, and we hope you can attend.
Have a great day, everyone. Thank you, Patty Dash, for all your information. Make sure you check out the chat feature. We'll leave it on here for a couple minutes because Patty had a lot of links and a lot of information in there. And if you miss anything, you can always email me and I'll make sure we get that information to you. So thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.
Bye,
Thank you so
everyone.
Bye.
much.
Thank you
Thank
for
you so
attending.
much.
Thank you. Patty had put her email in there too, so don't bombard her.
It's okay. Remember, I'm not a doctor, but I'll do my best to make sure you have the information that you need.
Yeah, but you're connected. You know where everything is, so.
I kind of know some people.
Yeah,
You know?
you do. You do. Thank you for inviting Dr. Cunningham. It was great.
Oh,
We
she's
would have never found
amazing.
her. Yeah. So super.
She's
All right.
amazing. She really is. And I
You're
can't
welcome.
thank this group for staying on, you know, after the time and
Mhm.
the chat interest that was there. Wow, it was a lot. So Dr. Cunningham, I'll have to report back to all that you were probably very, very popular here, 10 plus.
Absolutely. All right.
And I'm gonna, hey Patty, I'll leave my slides with you if somebody wants to take a look at, because there was a transplantation
Okay.
portion of it too. Okay,
Well,
Perfect.
the slides are on our website already.
perfect. Oh,
Under
perfect.
speakers notes. You can have access to them anytime. Have a great Saturday.
Thank you.
Try to stay
Thank
dry.
Thank you, Marty and Michelle. You guys are great.
Oh,
Oh,
thank
thank
you.
you.
We appreciate that.